Picture a man in his 50s sitting at his kitchen table one night with what he was certain was bad indigestion. A heavy, tight feeling in the center of his chest. He took an antacid, went to bed, but still had a nagging feeling in his chest. That feeling crept into his jaw and down his arm. But he kept telling himself it was nothing because he did not want to make a fuss. And if he was honest with himself, he was scared about what it could mean. By the time he decided to come into the emergency department, several hours had passed, and his ECG told us a horrifying story. It was not indigestion. He was having a myocardial infarction, what some folks call a heart attack. And those hours spent at home playing it off as indigestion had cost him heart muscle we could never get back. G'day team, I'm Dr. Cois, emergency physician, evidence nerd, and your guide through this fascinating world of medicine. Welcome back to Overheard in the Emergency Department. This is season 2 of the show, where we are focusing on helping you better understand what is going on under the hood of both your body and giving you some insight into what your doctor is actually thinking. The story in our opener plays out in my department more often than you might think. And here is the uncomfortable truth at the center of it. The person least able to tell whether the chest pain is a heart attack is the person having it. So in this episode, I will give you the warning signs we actually want you to look for and give you the framework to use when thinking about your symptoms and what you should do in the first 10 minutes before that window matters more than almost anything else. If you have not seen my ER or wait framework video yet, start there, because this is the deep dive on the biggest red light emergency of them all. But before we do, hit the like, subscribe, and alert bell so you never miss any of our content. All right, let's go. 2 facts make chest pain different from almost everything else we cover on this channel. The first is that time is muscle. During a myocardial infarction, a blocked artery is starving part of your heart muscle, and every minute that passes means more of that muscle dies. In a study of patients treated with emergency angioplasty, researchers found that every 30 minutes of delay measurably raised the risk of dying within the following year by around 7.5%. This is exactly why hospitals have targets for getting patients with myocardial infarctions to the cath lab, the so-called door to balloon time. And it is exactly why over the last few decades we have made incredible ground on reducing cardiovascular disease mortality. This all despite the increasing burden of LDL-related atherosclerosis. And there are a number of reasons for this. We have an aging population. That is, a larger percentage of our population has reached the age where the consequences of atherosclerotic cardiovascular disease come home to call. We are saving people from mortality so they get to that older age, and we have better treatments to reduce mortality. The second fact is the one that catches people out. A heart attack does not always look like it's portrayed on TV shows or movies. The textbook picture is of someone clutching their chest and then immediately dropping to the floor. But in a large US registry of over 400,000 confirmed myocardial infarctions, 33% of patients arrived to the hospital with no chest pain at all. These patients were more often older, more often had diabetes or heart failure, and were more often women. And because their symptoms were quieter, they waited longer, they were treated less aggressively, and they were more than twice as likely to die in hospital. In fact, their in-hospital mortality rate, that is dying, was 21% compared with only 9% in the patients with chest pain. So this is not about teaching yourself to diagnose, it is the opposite. It is about teaching you when to hand the question to someone who can make the diagnosis. So let's start with the classic pattern. The most common symptom is chest discomfort. And notice I said discomfort, not pain. People describe pressure, tightness, a squeezing sensation, or a heavy weight, like someone sitting on their chest. It usually sits in the center or just off to the left side, and it can spread to one or both arms, the jaw, the neck, the back, or the upper stomach. I like to use an acronym Socrates. So the site, onset, character, radiating and relieving factors, associated symptoms, timing, exacerbating factors, and severity. To that end, associated symptoms can include shortness of breath, sweating, nausea, lightheadedness, and a deep sense that something is very wrong. Never forget that last one. Oftentimes, I'll look at the patient from the end of the bed and know they are having a cardiac event. Now, the atypical pattern, because this is where lives are lost and we as physicians really start to earn our keep. Especially in women, in older adults, and in people with diabetes, an MI can show up without dramatic chest pain at all. It can feel like unusual fatigue, breathlessness on activity, jaw or back discomfort, nausea, or simply not quite feeling right. In that same registry I mentioned earlier, women were significantly more likely than men to have an MI without chest pain, roughly 49% versus 38%. If you have been told that an MI always announces itself loudly, please unlearn that today. Here is a question I get more than any other. How do I tell an MI from a panic attack? Because they genuinely overlap. Panic attack can bring on chest tightness, a racing heart, some shortness of breath, sweating, tingling, and an overwhelming sense of doom. Which, if you remember back to the previous segment, this sounds an awful lot like some of the symptoms we just talked about. I have cared for young, healthy people convinced they were dying who were simply having a panic attack. And I've cared for people who swore it was just anxiety, but were having a massive MI. So how on earth do you sort this out at home? The simple truth is there is no symptom checklist that lets you reliably tell these two apart, and especially not the first time it happens. A panic attack is something doctors diagnose after we have ruled out the serious and dangerous causes. It is not something you should diagnose in the moment by yourself. Come in, let us work you up and make that decision for you. And remember, time is tissue. A few things raise the stakes and should prompt you to call for help, even an ambulance. If you're over 40, if you have risk factors like high blood pressure, high cholesterol, diabetes, you smoke, or you have a family history of early heart disease. If the discomfort came on with exertion, or if this is simply not a feeling you have ever had before. When in doubt, you treat it as the heart until a professional tells you otherwise. So you or someone near you has the warning signs. Here is exactly what to do in order. Stop and sit or lie down. Stop whatever you are doing because exertion makes the starving heart work harder. Call 911, 000, or your local emergency number straight away. Do not wait to see if it passes and do not drive yourself. And I mean that. The ambulance is not a taxi. It is the start of your treatment. Paramedics can record your heart's tracing on the way, begin care, and take you to a hospital that is ready for you by getting on the radio and letting us know that you are coming. People who arrive by ambulance get treated faster because we know you are coming and we can grease the wheels so we can get that door to balloon time down. Then do what the dispatcher tells you. They may advise you to chew on an aspirin. There is good reason for that. In a landmark trial of more than 17,000 patients with suspected myocardial infarction, aspirin alone cut the risk of dying by roughly a quarter. Shockingly, in 1993, a registry of around 1,000 hospitals showed that only 77% of patients with an MI actually received aspirin. It is estimated that if all eligible patients were given aspirin, we would have 5,000 to 10,000 fewer deaths per year. But, and this matters only if emergency services advise it and you are not allergic, because not every cause of chest pain is helped by aspirin. Let the professional on the phone make that call. And one small thing that saves real time. If you can, unlock the front door so the paramedics can get straight to you. And here are a few other things to keep in mind. Know your numbers and your family history because your risk profile changes how seriously any chest symptom should be taken. If you're already on heart medication like nitroglycerin, follow the specific plan your doctor gave you. And please do not be embarrassed by a false alarm. We would infinitely rather see you and find nothing than have you stay at home and become the story I open my next video with. So to summarize everything we've talked about so far, if you have chest discomfort with pressure, sweating, shortness of breath, or pain spreading to the arm or jaw, you call emergency services. A heart attack does not always bring dramatic pain, especially in women, older adults, and people with diabetes. You cannot reliably separate it from a panic attack at home, so when in doubt, you call. And in those first minutes, stop, call, do not drive, and take aspirin only if advised. And how can you take this information and place it in the overheard two-tier system? Well, the best time to deal with an MI is years before it happens in a GP's office. That conversation about your blood pressure, your cholesterol, your blood sugar, and your family history is the one that quietly keeps you out of my department. A doctor who knows your risk is worth more than any symptom list I can hand you. If you have been putting that visit off, consider this your sign. Just take a look at the AHA guidelines for cholesterol management. Eat a plant-rich Mediterranean-style diet. That's a tier 1 habit. Exercise 30 to 60 minutes a day on most, if not all days of the week. Another tier 1 habit. And work on your stress and sleep. Again, a tier 1 habit. And that is your guide to chest pain. If it was useful, subscribe and hit the notification bell. Share this episode with the person in your life who always says they do not want to make a fuss. And tell me in the comments which emergency you want me to break down next. If you have not watched it yet, go back to the ER or weight framework video. I'm linking it right here because this chest pain deep dive is one lane of the bigger map. And next in this symptom episode, I am breaking down how to spot a stroke, where the same every minute count rules apply. Head over to drcois.com for the full companion blog post and full reference list. Let's chase less bad days and more good decades together. I'll see you next time, and hopefully not in my emergency department.